Welcome to the Deep Dive. Today we're taking what I think is the ultimate clinical shortcut, diving deep into Chapter 36 of the definitive surgical reference, Bailey and Love.
That's right. We're talking sports medicine and sports injuries.
And this isn't just going to be a basic overview. We're aiming for a focused, really systematic revision session here, one that's designed to arm you with the precise diagnostic and treatment algorithms for the most crucial athletic injuries.
And precision really is the key word, isn't it? We're trying to move beyond just the foundational anatomy and get into the clinical stratification that, distinguishes effective management from just generic care.
Okay.
We'll be moving systematically through the major joints, and we'll be pulling out the specific nuances, the tests, the imaging views, the graft choices, all the things that matter most in practice.
Our mission today feels a little bit dual. On one hand, we want to understand the mechanics behind the trauma, the forces that create that pop or that chronic ache. But I think more importantly, we want to give you the context to be well informed, to know the current standards of care, from, say, Tommy John surgery recovery times, all the way to the modern philosophy of joint preservation.
And that philosophy, it really starts right at the bedside. You see, effective management, it demands not only a precise clinical assessment, but also a really robust understanding of the injury's biomechanics.
The actual physics of it.
Exactly. The vector and the magnitude of the forces involved. And crucially, you have to align your treatment trajectory with the patient's specific competitive level and their, well, let's be honest, their often ambitious recovery goals.
Right. A Sunday league player's calculus is going to be entirely different from an elite sprinter's.
Completely different worlds.
Okay, let's unpack this with Section 1. The unique approach to taking an athletic history. We all know how to take a standard orthopedic history, but when an athlete walks through the door, what are the critical specific details that elevate this assessment from standard to specialized?
Well, the standard history is, of course, foundational. You can't skip it. But we needed these extra details that radically inform the prognosis and specifically the treatment planning.
Okay.
And the first difference is the precision we demand regarding the injury mechanism and the timing.
I mean, how specific do we really need to get on the mechanism? Is it enough for them to just say, I fell?
Oh, absolutely not. That's almost useless to us. We need the precise biomechanics. Was the knee twisted inward? Was the shoulder forced into, abduction and external rotation?
Were they decelerating on one leg?
Exactly. Understanding the vector of the force immediately helps you predict the likely damaged structures. And the timing, the exact moment the injury was sustained, is vital for managing acute swelling and, of course, for surgical planning.
So once we have the injury event documented in that detail, we immediately pivot to the patient's journey since the trauma.
That's the next step. We need to know what interventions and rehabilitation have already been attempted. Did they just rest for 2 weeks and then try to run again? Did a team physio start them on some specific exercises? This gives you a baseline of how the tissue is responding, their pain tolerance, their adherence history, which, it helps you project how difficult the next phase of recovery might be.
Then you move into quantifying the athletic load, which I find is often the most overlooked piece of data in general practice.
It is the diagnostic key, particularly for overuse injuries. It's not enough to know they play soccer.
You need the numbers.
You need the true training burden. How many hours are they training per week? And critically, how recently has that load changed? If a marathon runner suddenly doubles their weekly mileage, or a swimmer suddenly increases their shoulder stroke count, well, a stress fracture or a tendinopathy moves right to the top of your differential.
And previous injuries must be documented exhaustively, especially if they are related to the current complaint.
Oh, absolutely. An ankle that has been sprained 4 times already, that implies some underlying ligamentous laxity or, proprioceptive deficits that just have to be addressed.
So you're thinking differently about treatment from the outset.
Completely. It might require a far more aggressive bracing or even a surgical approach compared to a first-time sprain. The cumulative trauma history changes everything about the expected recovery and the prevention plan.
And finally, the question that really dictates the entire treatment trajectory. What are the patient's specific competitive goals?
This is where clinical science intersects with patient advocacy. If the patient is a high-level competitive athlete aiming for a specific season or a scholarship, the risk of recurrence becomes the overriding factor.
So you might change your whole approach.
You might. You might opt for a surgical solution for a first-time injury, like a shoulder dislocation, where you would normally attempt conservative management simply because the long-term risk of it happening again is just too high to jeopardize their career. Their personal goals inform your clinical risk assessment.
So once that comprehensive history is complete, the physical examination follows the standardized look, feel, move orthopedic system. But in sports medicine, the focus shifts heavily to the specific regional provocative tests we're about to discuss.
That's right. The tests that isolate a single structure, like the Lachman for the ACL or the Teller tilt for the ankle ligaments.
Let's start high up then with the shoulder, a joint that's balanced so precariously between massive mobility and, well, stability. The source material emphasizes a crucial difference in pathology, depending on the patient's age.
It's a huge differentiator.
Right. So if you're dealing with a younger athlete, usually under 30, particularly in collision sports like hockey or rugby, the primary concern after a traumatic event is acute instability.
And we know the classic mechanism for that: a forced, often violent, abduction and external rotation of the arm.
That classic tackling position.
Exactly. When the arm is leveraged this way, it literally pushes the humeral head out the front of the socket. And even if that anterior shoulder dislocation is reduced quickly, this leverage causes stretching of the anterior capsule and, far more frequently, an avulsion tear of the antero-inferior labrum.
Which is what we clinically call a Bankart lesion.
Precisely.
And that Bankart lesion fundamentally changes their risk profile, doesn't it? Because the primary stabilizer, the labrum, is now compromised, making them highly susceptible to recurrent instability events.
You've hit the nail on the head, but the moment the patient population shifts to older individuals, say over 40, the same mechanism, a fall or a tackle, comes with a much higher risk of an associated rotator cuff tear.
So why is that? Is the tissue just different?
It is. The younger athlete's labrum tends to tear off the bone, but the older athlete's tendon tissue itself is more brittle, more prone to tearing when it's violently stressed like that.
The clinical history often reflects this trauma vividly. The patient describes a violent injury and that immediate terrifying sensation of the shoulder being out of place. For management, what are the crucial history details we must chase down regarding the dislocation event itself?
Okay, so we need to know. Was it a spontaneous reduction, or did it require a trip to the emergency department?
How long was it out for?
Exactly. How long was it dislocated before it was reduced? Was there a history of prior subluxations or dislocations? And most critically, did they experience any extremity, numbness, or tingling?
And why is that nerve check so vital?
Because the axillary nerve wraps right around the neck of the humerus. It's highly vulnerable to stretching or contusion during an anterior dislocation event.
Right.
An injury to that nerve can cause deltoid weakness and sensory changes, which can severely limit rehabilitation, and it needs immediate documentation and monitoring.
And on physical exam, the signature finding for instability is anterior apprehension.
That's the classic test. You put the arm in the position of maximum risk abduction and external rotation. If the patient stiffens up, reports subjective discomfort, or, physically pulls away because they feel this sense of dread that the joint is about to pop out again.
That's a positive test.
That's a positive apprehension test, confirming instability. And beyond this, of course, we have to assess rotator cuff strength and always check neurovascular integrity.
Imaging starts with the basics, but the book is clear.
Yeah.
We need specific, high-quality views. I understand we need 3 views to confirm reduction and rule out serious associated fractures.
That's right. Standard radiographs need to include the true AP or Grashy view, which profiles the joint,
Okay.
the scapular Y view, which confirms the humeral head is centered in relation to the scapula, and the axillary or Velpeau view, which is really the best view to confirm anterior or posterior reduction.
And the purpose is twofold.
Ensuring the ball is back in the socket and detecting any bony damage.
And those bony damages are the classic Hill-Sachs and Bankart fractures.
Exactly. A Hill-Sachs lesion is an impaction fracture on the posterior superior aspect of the humeral head. It happens when the head slams against the anterior glenoid rim during the dislocation.
Right.
A glenoid rim fracture is a piece of the socket that breaks off, and often the Bankart lesion involves both soft tissue and bone. If we suspect these, we ask for specialized views. The West Point axillary view for the glenoid rim and the Strenker notch view specifically to evaluate that Hill-Sachs lesion on the humeral head.
Now, when does advanced imaging come into play? Specifically, when do you choose CT versus MRI?
If we are dealing with recurrent instability, we become deeply concerned about glenoid bone loss. If you lose more than, say, 20% of the surface area of the glenoid socket, a soft tissue repair alone is just going to fail.
So you need to quantify it.
You have to.
Mm.
In this case, CT, often with 3D reconstruction, is necessary to precisely quantify the extent of that bone loss. It's a critical measurement for surgical planning.
But for defining the soft tissues, especially the labrum and capsule in anterior instability, MRI is the standard recommendation. The source material listed this alphabet soup of soft tissue injuries: HAGL, GLELAD, LPSA, and general anterior labral tears.
For the learner, why does this distinction actually matter clinically?
That's a great question, because just listing acronyms isn't helpful. We need to know what they represent functionally. They are all variations of labral and ligament damage in the front of the shoulder, but they describe where the tear occurs, which really dictates the complexity of the repair.
Can you give us an example of how that complexity changes?
Sure. Take ALPSA, that's anterior labrum periosteal sleeve avulsion. The labrum is torn and peeled down, but the underlying periosteum is often preserved, meaning the labrum is displaced but still sort of connected.
So it's easier to fix.
It might be easier to pull back up and repair, but then you have an HAGL humeral avulsion of the glenohumeral ligament, and that means the entire ligament has torn off the humerus far away from the joint line.
That sounds much worse. It is a much more complex, technically demanding repair because you have to retrieve that ligament and somehow anchor it back to the humerus. These distinctions are what move the surgery from a simple labral repair to a much more involved anatomical reconstruction.
Management starts immediately post-reduction. The consensus seems to be that the patient gets a sling for a few days, but the key is avoiding prolonged immobilization.
Correct. Immobilization is short because we want to avoid joint stiffness at all costs. The early phase focuses on gentle, protected range of motion, often using pendulum exercises.
You have to keep everything else moving.
We really stress maintaining active range of motion in the distal joints, the elbow, wrist, and hand, to ensure nothing else stiffens up. We then progress systematically: passive, then active assisted, then full active ROM, culminating in targeted rotator cuff and scapular strengthening.
So the muscles can compensate.
Exactly, ensuring the muscles can compensate for any underlying instability.
Now, the surgical decision. The source material makes it clear that surgery isn't reserved only for recurrent dislocations. We consider it even for a first-time dislocation based on a risk stratification.
The risk stratification is paramount. If a patient is young, participates in high-contact or high-risk sports, and the imaging shows significant pathology, say a large Bankart lesion or a significant bony Hill Sachs,
The recurrence risk is just too high.
it's so high, often over 50%, that you might recommend surgery right away to stabilize the joint and protect their athletic future.
Can you outline that surgical continuum for us, starting with the least invasive options?
Sure. The surgical continuum ranges from primary soft tissue repair to complex bony reconstruction. We start with arthroscopic capsulolabral repair keyhole surgery to suture the torn labrum, the Bankart, back to the glenoid rim.
Okay.
If the soft tissues are severely stretched or damaged, you might opt for an open capsulolabral repair and capsular shift to physically tighten that stretched out capsule.
And what happens when there's significant bone loss, as you would have quantified on the CT scan?
If the bone loss is extensive, a soft tissue repair is, well, it's doomed to fail. We have to progress to glenoid bony augmentation procedures, like the Letarjet procedure.
And what does that involve?
That involves transferring a piece of bone, the coracoid process, and its attached tendons to the anterior glenoid rim. You're effectively rebuilding the socket and creating a restraint against further dislocation.
Finally, let's quickly address the older athlete who tears their rotator cuff during a dislocation.
That requires acute attention. If an acute rotator cuff tear is confirmed, especially involving the supra or infraspinatus, an acute repair should be considered. The modern standard is an arthroscopic repair utilizing a knotless linked double row construct.
That sounds incredibly complex. What does that specific nomenclature, knotless linked double row, actually achieve for the patient?
It's all about fixation strength and coverage. A single row repair anchors the tendon to the bone in one line. A double row uses 2 lines of anchors, which significantly increases the compression force and the surface area of contact between the tendon and the bone.
Which improves healing potential.
Massively improves it. And the knotless technique speeds up the surgery and avoids the bulkiness associated with knots, which leads to excellent patient-reported outcomes and really low re-tear rates.
Fantastic detail. And the differential diagnoses remain vital. Things like a proximal humerus fracture, greater tuberosity fracture, or an acromioclavicular joint separation.
Always keep those in mind.
Moving down the kinetic chain to the elbow, we shift gears entirely. We're going from general instability to the highly specific, repetitive stress injury seen in thrilling sports, the ulnar collateral ligament tear.
The elbow joint is inherently very stable, but the forces imposed during maximal velocity throwing are, well, they're astronomical.
Right.
The UCL, specifically its strong anterior band, is the primary restraint against valgus stress. That's the force that tries to open the elbow medially during a throw. This ligament runs from the medial epicondyle to the sublime tubercle of the ulna.
And the context here is almost always overuse in overhead athletes. Baseball pitchers, javelin throwers, or, tennis players with massive serves.
That's right. While an acute rupture can happen, the pathology is overwhelmingly chronic attenuation or repeated micro-tearing that leads to an eventual failure. We focus on the biomechanics. The UCL is under maximum stress, often exceeding its tensile strength, during that incredibly fast transition between the late cocking phase and the early acceleration phase of throwing.
That's the moment where the arm is maximally laid back just before that explosive delivery forward. All that incredible stored energy has to be resisted by that one little ligament.
Exactly. And this is why UCL tears are the signature injury of high-velocity pitching.
The clinical presentation seems to have two distinct routes, though one is far more common.
It does. The rare route is the acute injury. The athlete describes an immediate, unmistakable pop during a pitch, followed by intense medial elbow pain and just an inability to continue throwing with any velocity.
And more common one.
Far more common is the insidious presentation. They complain of nagging medial elbow pain, persistent tightness, and most frustratingly for them, a measurable and inexplicable drop in their throwing velocity or their control.
So on physical exam, we need to isolate that ligament and see if we can stress it.
We use provocative tests designed to induce valgus stress. The standard valgus stress test is performed, of course, but we often utilize the moving valgus stress test or the milking maneuver.
The milking maneuver.
Yes, as described in the sources, it involves the examiner pulling the patient's thumb downwards while stabilizing the elbow. This induces valgus stress through the range of motion. If this reproduces that sharp medial elbow pain, it's highly suggestive of UCL pathology.
And we must always check the nearby ulnar nerve.
It's mandatory. Due to the anatomical proximity, the ulnar nerve is very often affected. We check for sensory symptoms like numbness or tingling or any motor deficits in the hand. We also have to assess for ulnar nerve subluxation, which is where the nerve pops out of its groove during flexion.
And if the nerve is involved?
If the nerve is involved, we absolutely have to incorporate nerve management into the surgical or the non-surgical plan.
What about imaging? Radiographs first to rule out fractures and osteochondral issues.
Yes, standard views AP, lateral obliques, are required to rule out issues that are common to throwers, things like medial epicondyle avulsion fractures or posteromedial impingement. But for the UCL itself, dynamic ultrasound is hugely important.
Why dynamic ultrasound over an MRI initially?
Dynamic ultrasound allows for real-time visualization under stress. The examiner applies a valgus stress while scanning the ligament. This allows them to characterize the tear location. Is it proximal, mid-substance, distal? And crucially, to quantify the medial elbow joint space gapping when compared to the athlete's healthy contralateral elbow.
So you can see how much it opens up.
Exactly. If the gap is significantly larger on the injured side, it helps you gauge the severity of the tear. MRI is then used for the precise anatomical detail, defining the tear edges, checking the joint cartilage, and assessing the frequently affected flexor pronator muscle mass that overlies the ligament.
The first line of defense is conservative management, but it requires serious commitment from the athlete.
It demands months of strict commitment. It begins with total throwing cessation, no activity that stresses the elbow medially.
Not at all.
None. This is followed by a rigorous, structured rehabilitation program aimed at strengthening the secondary stabilizing muscles, the forearm flexors, and the muscles of the scapula to try and take some load off the ligament. Only after this foundational strengthening does the athlete embark on a highly gradual return to a throwing program.
The source material mentions biological options like PRP for partial tears, but it notes they aren't yet a true gold standard.
Correct. The evidence is still accumulating. They're appealing because they offer a non-surgical alternative, but they haven't universally replaced structured rehab or definitive surgery.
Now let's talk surgery, the famous Tommy John procedure, which dictates an incredible recovery timeline.
UCL reconstruction, or Tommy John surgery, remains the definitive gold standard for high-level throwers who require maximum stability and whose conservative treatment has failed. The procedure is technically intricate.
What does it involve?
It involves harvesting an autograft tendon, most commonly the ipsilateral palmaris longus, and routing it through bone tunnels drilled into the humerus and the ulna, creating a new, strong ligament.
And if the ulnar nerve was involved preoperatively?
It must be addressed. The reconstruction is often combined with an in situ decompression or, more commonly, transposition of the ulnar nerve, moving it to a less stressed position in the forearm to prevent future symptoms.
Let's pause on that recovery timeline, because this is what the athlete cares about most. It's often cited as 12 to 18 months. That is a lifetime for a competitive athlete.
It is a profound commitment. It requires patience and strict adherence to protocol because you are waiting for the tendon graft to incorporate, revascularize, and strengthen a process we call ligamentization. Rushing this process almost guarantees failure. The long timeline is the reason conservative management is always attempted first, especially for low-demand patients.
We should mention the evolving surgical option. Ligament repair augmented by an internal brace.
Yes, this is exciting because it stabilizes certain tear types, usually proximal acute tears, with a synthetic suture tape without requiring a full reconstruction. This can potentially offer a faster return to play, but reconstruction remains the prudent, long-term solution for complete mid-substance tears in high-velocity athletes.
And the differential diagnosis here must rule out a flexor pronator mass sprain, ulnohumeral arthritis, ulnar nerve compression, or a loose intra-articular body.
A lot to consider.
We shift now to a region that's often misdiagnosed.
Yeah.
The hip. We're specifically looking at chronic groin pain in young, active patients, where the presentation is often characterized by the unmistakable C sign.
The C sign is such a useful clinical marker.
It really is. When a patient cups their hand around their hip joint, pointing anterolaterally into the groin, forming that C shape with their hand, that should immediately trigger your suspicion of an intra-articular hip derangement.
Absolutely. When this presentation is chronic, especially when the patient has a history of repetitive, non-resolving diagnoses like groin strain or hip flexor sprain, you have to suspect the underlying morphological issues, femoroacetabular impingement, FAI, or, less commonly, hip dysplasia.
So these are problems with the fundamental shape and fit of the ball and socket.
Exactly. The ball, the femoral head, and the socket, the acetabulum.
The physical examination then focuses on reproducing the pain by forcing the joint into positions that exacerbate that morphological conflict.
Precisely. We assess hip range of motion, focusing on two key provocative tests. The signature test for impingement is the FDAR test. That's flexion, adduction, and internal rotation. This maneuver physically jams the misshapen femoral neck, the cam lesion, or the overcovered acetabulum, the pincer lesion, against the labrum, reproducing that deep impingement pain.
Does the FDAR test risk irritating other structures, or is it truly specific to FAI?
It is remarkably specific because that position, flexed, adducted, and internally rotated, is really the only way to replicate the contact zone of the impingement. Okay. We also use the Faber test, flexion, abduction, and external rotation, to stress the anterior structures and check for any sacroiliac or lateral hip pain. And importantly, the Stinchfeld test, resisted hip flexion. If resisted flexion causes pain, it strongly suggests a true intra-articular pathology is generating the discomfort rather than just a superficial muscle issue.
Given that these are problems of shape, initial imaging with standard radiographs is non-negotiable. It requires an AP pelvis and affected hip views, but the special views are crucial here.
To properly assess the coverage of the socket, we use the false profile view. But to detect a cam lesion, that extra bone bump on the femoral head-neck junction that causes the impingement, the 45-degree Dunn lateral radiograph is the optimal projection. This view profiles the femoral head-neck junction best, allowing you to measure the alpha angle and assess the size of that bump.
And when do we move to 3D imaging?
Because FAI can be a subtle 3D problem, CT is extremely helpful for better defining the bony morphology, for quantifying the extent of the cam or pincer deformities, and for precisely planning the bony resection. MRI is then essential for evaluating the soft tissue damage caused by the impingement, particularly the condition of the labrum, which is frequently torn or detached.
Initial treatment is conservative. Anti-inflammatory medications, specialized physical therapy focusing on core strength and hip muscle balance, and sometimes a corticosteroid injection.
Right, an injection to relieve pain and to confirm that the pain generator is intra-articular.
But the key concept here, overriding almost everything else, is joint preservation. Surgical intervention is only truly beneficial if it is performed before the development of significant joint space narrowing and established osteoarthritis.
Absolutely. Once the cartilage is severely damaged, the window for arthroscopic preservation is often closed.
So the timing is critical. If conservative measures fail and the patient has the right morphology without advanced arthritis, what is the surgical pathway?
For patients with FAI, the treatment is typically hip arthroscopy. This is highly specialized keyhole surgery that accomplishes two goals: repairing the torn labrum, often utilizing sutures and anchors, and performing a femoral osteoplasty,
Which is just shaving down the bone.
or trimming the acetabular rim for a pincer lesion. The femoral osteoplasty literally involves shaving down the excess bone to restore a normal, smooth head-neck junction, preventing future impingement.
And for dysplasia, which is an insufficient socket, the surgery is more radical.
Yes. Dysplasia requires an osteotomy, a procedure that physically changes the orientation of the socket, the acetabulum, relative to the pelvis. You're doing that to improve coverage of the femoral head, thereby increasing stability and decreasing stress on the cartilage.
And the differential diagnosis is broad here.
Yeah.
Adductor strain, athletic pubalgia, which is a type of sports hernia, evolving hip osteoarthritis, and of course referred pain from lumbar radiculopathy, all of which can present as groin pain.
It's a tricky area.
Moving on to the knee. This is ground zero for acute major sports injuries, especially in contact, cutting, and jumping sports.
It certainly is.
We know contact injuries, a tackle causing varus or valgus stress, often lead to complex collateral ligament injuries, like the MCL or LCL, plus secondary damage. But the most common major knee injury is the non-contact ACL rupture.
The non-contact ACL tear is a classic biomechanical event. It occurs during deceleration when the knee simultaneously collapses into valgus, so knocking inward, while the tibia externally rotates. This complex pivot shift forces the tibia violently forward beneath the femur, causing the ACL to rupture.
The history here is often dramatic.
It's the most pathognomonic history in sports medicine. The athlete hears or feels a distinct, loud pop, followed almost immediately by significant knee swelling, often due to a hemarthrosis, blood in the joint.
But the confusing part for patients is the recovery from that initial acute phase.
Exactly. The acute pain and swelling subside, and the patient thinks they are better. They often present to the physician months later, not because of the original trauma, but because of recurrent instability.
That feeling of giving way.
That feeling that their knee is giving way, particularly during any activity requiring cutting, pivoting, or sudden changes in direction.
The physical exam tests, therefore, focus entirely on the ACL's function, which is restricting the anterior translation of the tibia.
Which is assessed primarily by the Lachman test. This is the most sensitive test. It's performed with the knee in slight flexion, and you're assessing the quality of the endpoint and the amount of anterior translation compared to the uninjured side. The anterior drawer test is also used, but the Lachman is superior for both acute and chronic tears.
Radiographs are the starting point, even for a suspected ligament injury. We need AP, lateral, and merchant views. While they might appear negative, we are looking for critical associated bony signs.
And the finding of a second fracture is the most critical bony sign to look for. It's a tiny avulsion fracture of the anterolateral tibia caused by the capsule being pulled off during that high-velocity pivot shift event.
And if you see it,
If you see a second fracture, you can be 99% certain the ACL has ruptured, even before you've got the MRI.
and when we do move to MRI, what is the pathognomonic sign on the fluid-sensitive sequences?
We look for the kissing lesions. These are areas of bone bruise bony edema on the posterior aspect of the lateral tibial plateau and the lateral femoral condyle. They signify where the bone surfaces slammed together during the original subluxation, the pivot shift that tore the ligament. Confirming the ACL rupture on MRI is essential for surgical planning and for ruling out other internal pathology.
Treatment for symptomatic instability ultimately leads to surgery for most active athletes, as the goal is joint stability to prevent long-term degeneration.
We have to restore stability to decrease the potential for further, inevitable damage to the menisci and articular cartilage. The gold standard remains ACL reconstruction, but we are seeing a resurgence in select cases for ACL repair.
Tell us about the repair concept, like the bear technique.
Well, repair is appealing because you use the patient's own ligament tissue rather than a graft. It's only suitable for specific proximal tears right near the femur. The bear technique, bridge-enhanced ACL repair, is one such concept currently in clinical trials. It uses a biodegradable collagen scaffold to bridge the gap between the torn ends of the ACL, facilitating healing.
And if that's successful?
If successful, this could significantly change treatment protocols in the future.
However, reconstruction is still the established standard, and the choice of graft is critical for the durability of the repair.
For younger, high-demand athletes, autograft reconstruction using the patient's own tissue provides the best long-term durability and the lowest re-rupture chance.
And what are the options there?
The options are generally the bone patellar tendon bone, BPTB, the hamstring tendon, semitendinosus and gracilis, or the quadriceps tendon autograft. BPTB is often favored in heavy cutters or jumpers due to its strong bony fixation.
And for older patients?
For older or lower demand patients, an allograft, which is donor tissue, is a viable option for symptomatic instability. It offers less surgical morbidity.
Now, let's address meniscal tears, which are frequently encountered with ACL ruptures. The source material notes a significant shift away from partial excision. Why this evolution?
This is a crucial concept in modern orthopedics. We used to excise torn, symptomatic meniscal tissue rapidly, assuming the joint would tolerate it. But we now have irrefutable evidence that the menisci play a vital role in load distribution and joint preservation.
So every bit you take out matters.
Every gram of meniscal tissue you remove accelerates the inevitable development of osteoarthritis.
So the goal is now maximal tissue preservation.
Absolutely. The clinical philosophy now is, if it can be salvaged, it must be salvaged. We utilize specialized repair techniques, all inside out, outside in, and root repair techniques to stabilize the tear, especially in younger patients. Even if the rehabilitation is longer than a simple excision, the long-term benefit of preserving the meniscal integrity for joint health is paramount.
And the differential here includes things like patellar dislocation, PCL rupture, collateral ligament ruptures, and patellar tendon rupture.
A lot can go wrong in the knee.
We conclude the lower extremity deep dive with probably the most common acute sports injury, the low ankle sprain, which is ubiquitous in sports requiring sudden cutting and rotation.
The mechanism is nearly always one of inversion, the foot rolling inward, often combined with plantar flexion.
Right.
The ankle's primary resistance to inversion is the lateral collateral ligament complex. This consists of three components. The ATFL, anterior talofibular ligament, is the most frequently injured ligament. It prevents inversion specifically when the foot is in plantar flexion.
And the CFL.
The CFL, calcaneofibular ligament, is next most injured, and it resists inversion when the ankle is in a more neutral or dorsiflexed position. The PTFL is the strongest and is rarely torn in isolation.
Understanding that subtle biomechanical difference, plantar flexion versus dorsiflexion, is the secret sauce for the physical exam.
It's everything.
Clinical history is usually straightforward. They recall the inversion event, followed by rapid lateral swelling and bruising. Contralateral comparison during the exam is essential.
The physical exam uses two key tests to check integrity. The anterior drawer test is done with the ankle in mild plantar flexion. You stabilize the tibia and push the calcaneus forward. Excessive anterior halar translation suggests an ATFL injury.
Now let's detail the talar tilt examination and how ankle positioning isolates the different ligaments.
The talar tilt assesses the integrity of both the ATFL and the CFL. You apply varus stress, so inversion, to the talus. If you get excessive tilt when the foot is in mild plantar flexion, you are primarily stretching and testing the ATFL.
But if you change the position?
If you get excessive tilt when the foot is in slight dorsiflexion, you are now primarily testing the CFL. Knowing this distinction allows you to grade the severity and involvement of the complex very accurately.
The critical decision in the acute setting is whether to take radiographs, and for that, we rely on the highly effective Ottawa ankle rules.
These rules are crucial for cost-effective practice and minimizing unnecessary radiation exposure. You only need radiographs if the patient fulfills any of three criteria.
Okay, what are they?
Tenderness along the distal 6 centimeters or the tip of the lateral malleolus, tenderness along the distal 6 centimeters or the tip of the medial malleolus, or the inability to bear weight. And that's defined as 4 steps, both immediately after the injury and at the time of examination.
And foot radiographs are needed if there's tenderness at the base of the 5th metatarsal or the navicular bone.
Precisely, to rule out fractures like a Jones fracture. Advanced imaging like MRI is really reserved for cases of chronic pain, suspected osteochondral lesions of the talus, or syndesmotic or high ankle sprains which have complex ligamentous damage further up the leg.
Treatment for the vast majority of ankle sprains remains conservative. Rice rest, ice, compression, elevation?
We initially limit weight bearing, but the focus quickly shifts to aggressive rehabilitation. The priorities are managing pain and swelling, followed by prioritizing the strengthening of the peroneal muscles.
The ones on the outside of the leg.
The primary everators, which pull the foot outward and directly resist that inversion mechanism. This is followed by critical proprioceptive exercises like single-leg stance training to retrain the balance mechanisms. Supportive braces or taping can aid stability during the return to sport phase.
When is surgery finally indicated for an ankle sprain?
Surgery is reserved for patients who fail rehabilitation and experience persistent pain and recurrent debilitating ankle sprains, which indicates chronic mechanical instability. The standard surgical option is anatomical reconstruction.
And what does that mean?
It involves imbricating and shortening the attenuated ATFL, sometimes reinforcing it using local tissue like the inferior extensor retinaculum. Various non-anatomical reconstruction techniques exist, but are less favored than restoring the native anatomy.
And the differential diagnosis here is extensive. Anterolateral ankle impingement, peroneal tendon disruption, a fracture of the lateral talar process, syndesmotic sprain, and malleolar fractures.
A lot to rule out.
Now that we've systematically moved through the body's major joints, let's transition to the idea that specific sport mechanics create highly predictable signature injury patterns. Understanding the sport itself gives you a huge advantage in your differential diagnosis.
Absolutely. We're moving from generic trauma to the tyranny of repetition and specialized force transfer.
Let's look at the rotational sports. For golf, the sheer repetitive motion leads to overuse issues in the back and shoulder. But the classic golfer's elbow is a signature injury.
Golfer's elbow is a medial epicondylitis, a tendinosis involving the flexor muscle origins at the elbow. It's an issue of high gripping force and wrist flexion. Similarly, in tennis, we see tennis elbow, or lateral epicondylitis, which affects the common extensor origin. Clinically, it's often described as angiofibrous dysplasia of that origin.
And they both mostly respond to conservative treatment.
They do, but surgical debridement is an option if intractable.
Tennis players also suffer from something called tennis leg,
which is a partial rupture of the medial head of the gastrocnemius muscle, often sustained when they are pushing off explosively or suddenly changing direction. It's a very painful acute calf injury.
Rowing produces some truly unique and surprising injury patterns due to the maximal latissimus dorsi engagement.
The immense cyclical power stroke places massive shear force on the torso, and this can lead to rare injuries like rib stress fractures and intercostal muscle tears. In the forearm, they often get intersection syndrome, which is a friction tendinosis, where the tendons of the first and second extensor compartments cross each other on the back of the forearm.
Moving to the high-impact collision sports, American football and rugby. These are defined by unpredictable, violent forces.
In American football, the spectrum is wide. Concussions, severe fractures, twisting knee and ankle ligament injuries, hip dislocations, and turf toe.
Turf toe.
It's a hyperextension sprain of the great toe's metatarsophalangeal joint, very common when playing on artificial turf. Rugby is high intensity and often has low protective gear. We see risks of cervical spine fractures, frequent acromioclavicular joint injuries, shoulder separations, phalangeal dislocations, and the notorious jersey finger.
What exactly is a jersey finger?
It's an avulsion injury where the flexor digitorum profundus, or FDP tendon, the one that flexes the fingertip, is pulled completely off its attachment at the distal phalanx. It often happens when a player grabs an opponent's jersey and the finger is forcibly extended while they're trying to flex. It requires surgical repair.
High-velocity throwing sports like javelin mimic baseball's kinetic chain issues.
They require efficient energy transfer from the ground up through the hip, the core, and the shoulder. Faults in any part of that chain result in abnormal stresses higher up, leading to UCL injuries in the elbow, shoulder instability, and tendinopathies.
Swimming is often considered low impact, but the constant repetitive overhead movement of the crawl and butterfly strokes creates its own pathology.
The repetitive demand on the shoulder leads to multidirectional instability, so laxity in multiple directions. What's interesting is that this laxity can sometimes give the swimmer a competitive advantage by allowing a longer stroke.
But can become a problem.
It can quickly cross the line into pathological instability, causing pain and dysfunction due to muscle fatigue and impingement.
And finally, a look at the extreme demands of ballet dancing, particularly the on-point position.
Ballet places unique posterior stresses on the foot and ankle. We see posterior ankle impingement and flexor hallucis longus, FHL tendinopathy, often called dancer's tendonitis because the FHL tendon runs through a tight sheath right behind the ankle. The constant high load also leads to stress fractures.
And the source material specifically highlights the concern for female athletes here, linking stress fractures to the female athlete triad.
That's a critical point to note in this patient population. The female athlete triad is the dangerous combination of disordered eating, amenorrhea, which is a loss of menstrual cycle, and osteoporosis, or low bone density. If this triad is present, stress fractures in the feet or shins become highly likely, and the management must address the underlying systemic metabolic deficiencies, not just the orthopedic injury.
Lastly, the high-velocity outdoor sports, snowboarding and skiing.
Here, the equipment dictates the injury pattern. Rigid ski boots protect the ankle but transfer massive forces up, increasing the risk of severe tibial fractures and knee ligament disruption, especially the ACL.
And snowboarders.
Snowboarders are prone to wrist fractures, as novice riders often fall backwards onto outstretched hands. All levels risk acromioclavicular joint injuries. And chronic runners, like marathoners, suffer chronically from iliotibial band syndrome, or ITBS, and stress fractures in the lower limbs.
What an incredibly detailed exploration. We moved systematically from the specialized assessment, detailing the crucial importance of quantifying athletic load and competitive goals, all the way through the 5 major regional pathologies. We really covered everything from the age-dependent pathology of the shoulder to the 18-month commitment of Tommy John surgery.
And the true takeaway for you, the learner, is not just knowing the diagnosis, but knowing the precise algorithm. Understanding that the FADR test confirms the C sign of hip impingement, or that a second fracture is pathognomonic for an ACL tear, or that you use plantar flexion to test the ATFL, these specific details are the true shortcut to being an effective clinician in sports medicine.
And the overarching theme we found in the hip and the knee is this urgent modern necessity of joint preservation. We are moving away from excision toward maximizing tissue viability, repairing the meniscus, using ACL repair scaffolds, and performing early hip arthroscopy before osteoarthritis destroys the joint.
Reflect on how rapidly this field is moving. The key is to stay informed on the techniques that are designed to preserve the joint's natural function.
So here's our final provocative thought for you to consider. Of all the rapidly evolving surgical techniques we discussed today, the knotless, linked, double-row rotator cuff repair, the bio-augmented ACL repair techniques like the bare scaffold, or the ligament repair with an internal brace for the UCL, which one do you predict will break away from being an alternative and definitively replace its current gold standard counterpart 5 years from now? The speed of innovation in sports medicine means today's best practice is tomorrow's history. Thank you for joining us for this deep dive.